All right. Well, I just wanted to welcome everyone. This was a project that I wrote the proposal, but I had a little kick to do it from everybody's favorite CEO. It started out as a very small project, and it has really become something that I think the K&A can be proud of, and that I'm proud of too. And I hope that we all get a little bit of information, but also a little push to go out there and make a difference. That's really what this was all about.
Judy?
Okay, here we go. First of all, I'd like to thank Delanor and Donna and Teresa for allowing me to moderate tonight. I'm very excited to be your moderator. First thing that we're going to do is I'm going to introduce our expert panelists. We have a very robust panel tonight, and I think that you're going to be very excited about the discussion. First, we have Dr. Camille Burnett, an advanced practice public health nurse. She is an associate professor in the College of Nursing at the University of Kentucky and the Crawl Day Endowed Professor in the Center for Research on Violence Against Women. She is the co-director of Integrated Special Populations with the UK Center for Clinical and Translational Science. Dr. Burnett has a doctorate in nursing health promotion, a Master of Public Administration from the University of Western Ontario, and a Bachelor of Science in Nursing from the University of Alberta. Welcome, Dr. Burnett.
Thank you.
Next, we have Dr. Natasha Jarnette. She is an assistant professor in the Christina Lee Brown Environment Institute at the University of Louisville, Division of Environmental Medicine, researching the health impacts of extreme heat exposure and environmental health disparities. In addition, she is a professorial lecturer in environmental and occupational health at the George Washington University Milken Institute School of Public Health. Dr. Jarnette has a doctorate in public health sciences and a Master of Public Health from the University of Louisville. Welcome, Dr. Jarnette.
Thank you.
And our third panelist is Rebecca Hollenbach. She is the Executive Administrator of the Center for Health Equity. She is an experienced analyst dedicated to improving efficiency and advancing equity within government. Her skill set includes qualitative, quantitative, and geospatial data collection and analysis, with ability to use data to drive a larger strategic plan. Ms. Hollenbach has a Master of Public Health from Emory University and Bachelor of Science in Biology and a Bachelor of Arts in French from Ursinus College. Welcome, Rebecca.
Thank you.
So we will get started with our questions. The first question I would like to ask addresses all three of you all. So I would like all three of you to answer this question regarding the movie. Was there underlying structural racism that impacted the number of deaths and incorrect counts seen in this severe heat event? So we can start off with, how about Dr. Burnett?
Great, thank you. So that's an easy yes. Right off the bat, I think I see all the head nodding that's going around, and they were really explicit in the movie about articulating that as well, that the root cause, which really was metaphorical for some of the different areas around the heat that were talked about. For me, racism is at the core and is the root cause of all of the disparities that we saw, and we see them playing out, even now with the pandemic that we're experiencing. But we have to recognize that it's one of those prolific social conditions that are causing Black and Brown people to disproportionately die far too soon, and also exacerbating a lot of the underlying conditions that made them more susceptible to what we experienced and saw people experiencing as a result of the heat wave. And so there's more things that I can talk about in terms of where, we see it manifest itself. And I think, I want to make some space for our other panelists, but I think it's important to recognize that there's an insidious nature that presents itself with structural racism, and that it shows up in these conditions in various ways, but it's very recognizable. And poverty is one such manifestation of that, amongst other things. And I think the video did a great job of going through some of the structural, meaning the policies that really started to show how racism is so deeply embedded historically and as well structurally. So I'll pause there and allow my other fellow panelists to also chime in.
Very well said, Dr. Burnett. Agree 100%, just as you saw heads nodding. Mine is certainly one that agrees that underlying structural racism certainly contributed to the massive loss of life and even reactions to that massive loss of life from the Chicago heat wave. I am thrilled to be here. And I want to say I'm so excited to be here to talk to you about this, but this is a tough subject. This is a sad, heartbreaking subject. The movie was quite heavy, or the film was quite heavy. So I don't want to be insensitive and say, I'm so glad we're discussing climate change this evening, but I'm so grateful for the opportunity. I am a climate nerd. I spend time in climate. I will speak to this as a climate event. And what's important for all of us to know is that we're all at risk to the health threats of climate change. Climate does not discriminate, but our preparedness for it, the way our neighborhoods are configured, and the responsiveness to it, that is subject to discrimination. And that's what we've seen play out here. As the film narrator very eloquently pointed out, redlining is at play, and it's still at play today. And we'll say our communities aren't subject to redlining now, but historic communities that were subject to racist redlining practices that determined where communities of color were, those communities bear a heavier set of climate unfortunate climate events. For example, heat, which was shown here. And there was a study that was published just last year in the journal Climate by Jeremy Huffman and others that showed that across the nation, communities that were redlined have higher heat, significantly higher heat all across the nation. There was just another study that was published in the last couple of weeks that also demonstrated these same links between redlining and flooding. And so that's something that we have to consider when it comes to these types of crises, that people don't necessarily live where they live by choice. It's not all a factor of choice. These are communities where people's families have resided, and they have social connectedness and social ties there, and disrupting that is also not good for health. But these redline communities bear such a heavier burden, and she laid it out really, really carefully in the video to overlay the redlining with poverty, with race, and so forth and so on. There are many populations that are susceptible to extreme heat that have been discussed in the film: older adults, children, people with chronic illness. And so we have that layer of vulnerability on top of having a higher burden of exposure to extreme heat. Pausing for a moment, the communities that are redlined are also known to be hotter, as I pointed out, but I want to give you a number actually on how much hotter, because urban heat islands can be 5 to 7 degrees hotter during the daytime. You may think, okay, that doesn't sound like a big deal. The EPA reports that they are 22 degrees hotter on average at night. So this much hotter, that is an infrastructure challenge. And these communities also have less infrastructure in terms of medical care, in terms of backup housing, in terms of having food banks. So having that less infrastructure to support emergency response, plus also having a higher burden of exposures, and this is induced systemically, can pose quite a bit of challenges for this community. So I'm glad for this question. I'm glad we're speaking of it in these terms, and it certainly does make a very strong case for systemic racism.
Yeah, I'll just second everything that they have both said. I think at one point in the movie, she was asking about, was this because of race? And I always like to be very clear that it's about racism and not necessarily inherent properties of various races and ethnicities. So the problem is systemic decisions that have been made. These were referenced in the movie redlining, for example. In Louisville, we have a very well done map of redlining where you can kind of see the original maps that prevented people from wealth building and buying houses, prevented people from getting loans that were federally subsidized as part of the GI Bill. And unsurprisingly, these are the same areas that have higher rates of poverty now today. One of the ways that we kind of help people conceptualize this in the Center for Health Equity is by using what we call the tree metaphor. So thinking about the outcomes that we see and the patterns in the outcomes as the leaves of the tree. So these would be things like heat deaths. These would be things like premature death due to diabetes or life expectancy differences, right? You can see these in our 2017 health equity report for Louisville. You saw some of these in the maps they did post-mortem in Chicago. And so whenever you see patterns kind of by geography or by populations or demographics, you really need to ask, why are you seeing that, right? Because when you think about the tree, the health of the tree doesn't necessarily start in the leaves, it starts in the roots. So these are what we call root causes. So thinking about the film, some of the things they talk about are housing quality, right? Safety of a neighborhood, things like income, right? Do you have enough income to buy generators or fans or air conditioning? Do you have resources in your community that you could go to get a respite, right? And we see patterns. They do a very good job illustrating the different patterns in the neighborhoods that they see across Chicago and how some neighborhoods had resources and were not affected and others did not have resources. And so then when you see those patterns and root causes, you again have to ask yourself, well, why do we see those patterns? And we use that metaphor to talk about the soil, right? What nutrients are available to the tree. And that is what we call systems of power. So these are things like racism, sexism, classism. These are all of the ways that people make decisions that then shape policies and practices, both historical and current. Something that really struck me, like I was just thinking about the quote, the more things change, the more they stay the same, right? It's like, we still see these same patterns, right? We have Chicago, we have Katrina, we have COVID-19. There were so many parallels between the way that things happened in Chicago and Katrina, and even now, the way things are resourced, what's considered an emergency response, what's not, what's considered a disaster or a crisis, and what's not, what motivates people to apply funding and public policy. So, so much to talk about tonight, but just to echo Dr. Jarnette, I did one thing that was really apparent is just the level of trauma that occurs in communities from racism on a regular basis, but also when you see kind of severe disasters or stress events like a heat wave. And what does it mean to lose several people that you know? You know, this is even something we're seeing in COVID, where certain communities have experienced a lot more loss than other communities. And so thinking about the mental health impacts too. So lots to unpack tonight.
You know, I think we could have just stayed on this one question, to be quite honest, because as both of you were speaking, there were other things I just wanted to jump in and say, oh yeah, you know, I wanted to add this or that. But a key point about the trauma, I just want to reiterate that, is there's also the generational trauma, because you have a community that has historical trauma and recurrent trauma and cumulative trauma. And all of those tear at the fabric and the core of those communities as well. And there's, you know, we have evidence and mounds of research on the epigenetic effects of that too, in addition to all of those things as well. And in addition to what Dr. Jarnette said about, you know, some of the policies, and we initially started talking about the redlining, there's also a historical element to those policies, right? Redlining is an exemplar that was brought forward, but let's remember that there's been generations of policies that have perpetuated and reified racism in very many ways. And we can think about voter suppression, segregation policies, educational policies. And so there's a cumulative effect as well. So redlining, just for the audience to know that that was an excellent exemplar, but that's not just that's just one of several policies that have really had severe and tragic impacts on these communities.
Yeah, to add on to that, Dr. Burnett, another example they give is kind of the destruction of Halstead Street. So if you look to Louisville, basically there are examples of this everywhere across the country, because this was federal policy and practice. And so wherever it happens in one community, it happens in another. It's just different names. So kind of with urban renewal in the 70s, there was a thriving Black economic center that got destroyed. And in Louisville, that version was Walnut Street, which no longer exists. It's now Muhammad Ali Boulevard, right? So we see these patterns, and there's, to be honest, we could spend the entire session tonight talking just about all of the policies. But there are lots of great resources out there that kind of go through those. Even in Louisville, there's been a ton of excellent work from Metro Housing Coalition, who's done a lot of that. There's the University of Louisville and Braden Institute of Social Justice has a lot of great resources. So
I love the follow-up that both of you have shared and additional information. I want to throw in one more sentence. If we haven't made the case strong enough that systemic racism was at play, I want to give you another example within environmental health, air quality. In terms of frontline communities, the communities that live closest to air polluters, industry, are often communities of color. And the father of environmental justice, Dr. Bob Bullard, he researched this back in the 90s and published a paper at the beginning of the environmental justice movement that demonstrated that its race is the most powerful predictor of where these hazardous facilities are located. Race, not age, not income, not gender. Race was the most powerful predictor. He came back again and did that study just a couple years ago. I don't want to say the exact number. I want to say about 2017, but don't mark my words. He did this again, and race is still the most powerful predictor. And this is how this continues. This is how this persists today, and how we're continuing to see these disproportionate burdens on certain populations.
Very, very excellent discussion. The next question that I would like to pose, and I would like Dr. Jarnette, could you start us out and answer the following question for us? Should nurses be involved in policy when it comes to climate change, and why or why not?
Absolutely. I have spent much of my career in nonprofit associations, and much of our work has been around identifying who the key messengers are that can help advance policy. Nurses are key. Nurses first. I celebrate you. You are the most trusted health professionals. I will take a step back. Public health is not the most trusted health professionals. Medicine is not the most trusted health professionals. It is nurses are the most trusted health professionals. So people trust and value what you have to share. So you have a unique experience. You experience this in the clinic. You see how different climate events are impacting your community. You see how extreme heat will mark an uptick in hospital admissions, for example. And you have lived stories that you can share that make a difference. Storytelling is key when it comes to policy. We have been telling people about environmental health issues, climate issues for decades. People have known that climate change is a threat to health at least since 1923. The American Public Health Association has their Public Health Climatology Committee published their first report in 1923. What they said then is what we're experiencing now. Perhaps if it were nurses that shared this story, it may have been heard more and taken into context. But you have stories to share that are very unique to everybody else's experiences with climate. Nurses have the ability, so not only do you have these unique experiences, but you have this expertise to understand uniquely how it impacts health. Bringing all that together, your research abilities, your ability to educate not just the general public, which is extremely important in this case, but you can educate policymakers, you can educate decision makers through your experiences professionally. And that can inform advocacy. And then you can also put this into practice. So I think nurses are uniquely positioned and uniquely skilled to be able to do that. But on top of that, from all the tests that are out there, you're the most trusted health professionals. And so you are key messengers in being able to make a difference in this. Great question. Thank you.
Just to add to that, I think everything you said is so spot on. And, you know, I work for the Center for Health Equity, which is part of Louisville Metro's Department of Public Health and Wellness. So doing health equity work is my literal job. But I think that if we're going to solve some of these systemic issues, everyone is going to have to make equity a central part of their job. And, you know, everyone has a really good understanding of how that interplays with their profession and their job and their daily life. And so you're going to be able to be the best advocate in your profession. And also, you know, as Dr. Jarnette mentioned, you are trusted health professionals. And so I think the storytelling aspect is really important as well, thinking about, okay, how can I make sure that I'm highlighting these systems and these structures in the stories that I have from my community to make it more apparent how kind of this is a pattern. It's not just one individual's unique experience. This is something that we see consistently, and we see inequities across our community. So I think it's really powerful to have people who take the time to develop an equity lens, who take the time to make sure that advancing equity is part of your career and everything that you do. And I think that's how we start seeing a lot of change.
And I have to chime into my nursing colleagues around this one for sure. Yes to both of you. And in addition to that, this is the root of our practice. Social justice is the root of nursing practice. And this is our history and this is our legacy. And because of that, we have a moral imperative. We bear witness to all of these aspects of suffering. And because we bear witness, we have a moral imperative to do something about that. And so I agree that it is a responsibility of many professions, and I don't feel that we can address these issues in silos. Clearly, that's not the right approach. And nursing is very much a profession, as it was said, we are the most trusted profession. So how do we leverage that to be able to move these issues beyond, aspirational language towards action? what does that look like? How do we prepare ourselves to be more on the ground change agents, right? And so part of that is sort of really setting a reset in terms of, where our priorities are, what do we focus on, how do we integrate that into our education, the types of nurses that we are turning out, and sort of reprioritizing this back into sort of our historical roots of our practice. And, ironically, environmental justice was one of the original aspects that people love to refer to Florence Nightingale. And so I will do so accordingly. That was really the root of her practice, was environmental justice policy work. And so in addition to that, we have people who, like Sojourning Truth and Harriet Tubman and all of those wonderful nurse leaders who took on issues of injustice and social issues and moved them forward. So I just encourage my nursing colleagues to just live in that legacy. And definitely this is at the heart of what we do and who we are.
That's great inspiration. Great. We have a question from the chat box, and this is from Brenda Hackett. And her question is, from your perspectives, can you give examples of how we can begin to disrupt systemic racism in Louisville? How about Ms. Hollenbach?
Great. Yeah, I mean, I think the thing that we have to remember about systemic racism is that we have to be patient and persistent, but still move with urgency, right? So this is not a situation that we are in because of just one singular action or choice. It's a accumulation of hundreds of years of decisions and choices that had specific racist intentions. And so it's going to take a lot of years of specific anti-racist intentions, engineering policies and practices that are specifically trying to undo racism. So some of the tools and methods that we use to think about this in the Center for Health Equity, well, one is a framework that we use called normalize, organize, operationalize. It comes from the Government Alliance on Race and Equity. And kind of the premise behind that is that you start within an organization. You might start by normalizing. So one example of this is doing these movie nights, right? Getting folks to have shared analysis, shared language, shared understandings of what the priority should be. And then the second is organizing. So this comes to how are you actually allocating resources within your organization? What initiatives are you funding? What positions do you have? And then the third is, once you have an infrastructure in place, is thinking about how do you operationalize? How do you put this in practice? So these might look like applying tools like a racial equity tool to analyze your decisions in advance to figure out what the impact might be. This might look like changing funding and evaluating programs, thinking about, is this getting us to a more equitable state? Another framework that we use is thinking about the socio-ecologic model. So it's very jargony, but essentially think of it as like an individual is nested in different layers of society. So sometimes we focus first on individual responsibility, right? You saw that emphasis from the mayor in Chicago who said people just didn't take good enough care of themselves, families didn't take good enough care, right? So we know that individual and interpersonal actions are important, but they're also shaped by a lot of other conditions that people are experiencing and embedded in, right? So individuals and their networks are inside of organizations, right? They belong to different organizations and institutions. And these organizations belong to communities, right? And these communities are governed by policies. These could be informal or formal. And so when you're thinking about change, one of the things that this model teaches us is that if you want to start seeing differences in outcomes, you actually have to intervene at all levels of society in order to make that most effective, with the understanding that policy level change and community level change are the most important levers to be pushing on, so that you can kind of see the conditions that people exist in shifting. And so that's a lot of theory, but in practice, what that looks like is thinking about, as you make decisions, say, sometimes people get overwhelmed because they're trying to address 400 years of racism at once. And so I think sometimes it can help just to start thinking about the organizations you belong to and figuring out what needs to shift in my organization. What, like, for example, with Kentucky Nurses Association, I know Delanour has set a lot of goals around shifting education or shifting resources, right? And so I think that starting with your organization and seeing what change you can make is helpful. And then also thinking about what are policies that are happening or what's an agenda that we might want to set that we think would be anti-racist or would further health. So yeah, obviously I had a lot of thoughts about that one.
All right, Dr. Burnett, when we look at the people who were most affected in the film, what public safety issues might have been put in place to prevent their isolation, such as nailing the windows, shut?
Well, I was just getting ready to answer the structural question, but I will answer this one because I think it's really important. And I feel like, again, right away, I go right to systems, right? And get to the root cause of what created that in the first place. But if we look at the fact that this has happened and this was a situation that was unfolding and occurring, I think one of the great areas of, as a nurse, that, we really could beef up a bit more is our community presence and our population and public health nursing. And I think this is where, we can really lean into reorganizing our financial resources, our structural resources, our systemic resources around population-focused health priorities, and really mobilizing that on the ground neighborhood community health approach. I was just going to say community health nursing, but I recognize there's other practitioners on the phone where their expertise is also needed in the community and at that level as well. And because Rebecca had mentioned that ecological model, again, we have to look at, how do you support the individual? How do you support the neighborhood? How do you support the community? And then how do you support the system? And so the interventions had to happen at all of those levels to start really dealing with prevention. And we can't just stay downstream and always wait till something happens and then scramble around and try to figure out how to fix it. We have to also think proactively versus reactively. And that's sort of the piece that I was going to weave into the structural aspects as well, as when we think about how do we start to mitigate some of these challenges that people are facing, we have to stop trying to retrofit solutions at the end and start to look at them from the beginning and anticipate that these circumstances were predictable. This was a predictable disaster, right? This is why they said it was something that, I think they alluded to that basically on the film. I'm not sure, I can't remember the exact wording. And so because of that predictability, we can proactively start to address those things. So there's a proactive piece that definitely needed to be addressed. And then there is all of those spaces sort of in between. So I know that's sort of a long-winded answer to your question, but I don't feel it's just one space that needed intervention with this situation. It's all across those different aspects where we need to build in sort of support and restructuring and remedying and all of those types of things.
If I may chime in, I love what Dr. Burnett has shared, and it causes us to think of this from a much wider perspective. I think what's really important here in terms of being able to address the safety issues is to meaningfully engage the communities. It was upon engaging the communities when it appeared that it's not just a head-on extreme heat issue that contributed to the outcome there in Chicago. There's a safety issue at play where people's windows are nailed shut for fear of physical safety, but they also had this, this threat of climate events that was happening at the same time. And so addressing the safety in the communities may involve a lot of different aspects, but it's got to start with meaningfully engaging the community to help identify what that solution is, because they live this experience and they have their expertise in their own right of their personal experiences. There's much that could happen by way of neighborhood watches and community safety patrols and more lights. Something underlying is addressing mental health. Addressing mental health issues as well. But there's a lot that could be done, but the community needs to be there at the table to help inform the solution. And going back to the previous question as well, in meaningfully engaging the communities, we need to be ready to listen to the community. I like to advocate for community-based participatory activities. That is where, when usually in the research community, the community is involved from identifying what the problem is all the way through evaluating what the intervention is. So they're there every step along the way to inform the decision making. This gives power back to communities and also ensures sustainability and longevity of the intervention that's put into place. I also recommend health in all policies approaches. This is a framework that involves multidisciplinary experts, including the community, to be at the table to ensure that health is included and considered in whatever policy is being determined, where health isn't often at the table when it's a transportation decision that's being made. This puts health, public health, nursing, environmental health there at the table to inform that. The other key thing about health in all policies, and I know Ms. Hollenbeck is an expert in it because Louisville Metro is really stellar in the nation on executing health in all policies, is that equity is at the center. And that is key to ensuring health equity moving forward. I'm reminded of a phrase, you can't fix what you won't face. So we have to address that there's systemic racism that has contributed to the health outcomes that we're seeing. We have to see that, we have to face it and address it. Also, we need to think of communities from a place of strength. We often think of communities that are more sensitive, that are adversely burdened, and we think, oh, they need our help, and this is so bad what's happening to them. And that is all true. But these communities have strength in their own right. We no longer call these communities vulnerable communities because these communities have been making a way out of no way for generations. And we need to tap into that strength to be able to identify the solutions and to be able to empower communities for better health. And wonderful question, thank you.
That brings us to our next question. And I would like, if possible, this may be our last question because of time. So I would like each of you to answer the following question regarding specifically disaster preparedness, okay? And what I'd like to know is, can we build a proactive disaster relief plan? And what would that look like? And how could we pay for that?
So something that kind of came up in the film was they were talking about what's considered a disaster. And a lot of public health's disaster infrastructure actually exists and is funded because of 9/11. So after 2001, the federal government created the Public Health Emergency Preparedness Program. And so there have been millions of dollars that have been put into that program. And I think something that's interesting about disaster preparedness is that it's very much, it's based on a military emergency response structure. And so something that I kind of think about is where is the best way to use people's skills to kind of proactively prevent this, right? So I think that when we say disaster preparedness, what we're actually talking about is, in some ways, how do we prevent further racism? How do we undo the effects of racism, right? So we're seeing that communities experience the same disaster, but have disproportionate outcomes, inequitable outcomes, because we have all these years of social policy. So I think some of disaster preparedness is actually shifting our mindset and realizing that we need to take into account, what do people deserve from their government? What do people deserve in terms of subsidies, in terms of public policy? One thing that Louisville actually has is a resilience plan. This was funded by the Rockefeller Foundation, and it was created specifically to address this question. As we have more climate change, how is this going to impact communities? And one of the things that came out of Louisville was that this exact same thing that we've been talking about all night, which is that those communities with the most resources are the most prepared to face climate change and climate disasters. And so a lot of our resilience plan is actually focused on social policies, improving education, improving income, improving health outcomes, because all of those things will make your community more resilient and more prepared to take on when there are disasters.
Great. Dr. Burnett?
I was so enjoying just listening to that, because, you know, we're both sitting here, you know, head nodding, and it's wonderful that we all have the same orientation. But you're right, there's an ideological shift that has to happen in terms of what our priorities are and what our values are and where we're spending their resources. And in terms of the cost, I see that as an investment, right? And where do we want to invest our money? And really thinking about the return on that investment. Oftentimes you hear the public health slogan about, you know, public health in terms of the return on investment. And so really, again, it's this, either you put your money upstream or you put it downstream. Either way, it's going to be spent, and it's better spent upstream at more cost efficient upstream spending versus downstream spending. And when I had thought through this, thinking about this question, I too am a health and all policy person. I agree with that. I think it's something that is an approach that really needs to be taken. And if we do use that approach, then this would be a byproduct of that type of thinking anyways. That would be naturally embedded across all of those different systems. Earlier, I mentioned having this silo approach, and I really believe that if we were really to think about, you know, focusing on this preparedness for all of these other social conditions that we know are existing, then we need a multi-sectoral approach. We need to be interdisciplinary in approaching all of these areas that definitely need some work. I'm originally from Canada. Some of you might not know that. And while I was there and I was growing up in that public health system, so to speak, there actually was a declaration of a natural disaster, and that was around poverty and declaring poverty specifically around homelessness as a natural disaster. And what was recommended in one of the urban centers was to use 1% of the federal, provincial, and municipal budgets to combat this as a natural disaster. And so narrative and language matters. And I know that some of this did come through in the video that we got to see, but I do feel that, you know, as we start to recreate and co-create our systems around, you know, I don't believe there's a post-COVID time. I think this will be a neo-COVID time, and things are going to be different. And there's an opportunity here for us to start languaging things in a different way and speaking a different narrative and restructuring in a different way. So, and I'm aware you're conscious of time, so I will stop.
Yes. And we're going to have to stop there. We could talk about this subject so much longer. We've only hit the surface. So I want to thank all three of our expert panelists for the wonderful job that you did tonight. And I'm going to turn it over now to Teresa. She has a few words I think that she'd like to say.
I want to thank everyone for attending this session of Intersection of Social Justice and Healthcare Movie Night. I want to really thank our panelists. The discussion, we probably could go days and days and days, and I really think it's important that nurses understand their role in social justice as it relates to everything, but particularly healthcare, which is, you know, where we work. This project came about as a platform to recognize racial injustices, how healthcare impacts those injustices, and the impact those injustices have on health. Unfortunately, this pandemic has highlighted the inequities that exist within healthcare. Now we have to consider as a profession, what are we going to do about it? We thought this project would get about 15 participants each night. We've done a little bit better than that, haven't we, Delanor?
What an understatement.
It has become so much more than what we anticipated it to be. It's a way for us to learn, have dialogue, create. It's become a fellowship at a time when nurses need support, recognition, and their value amplified. These movie nights have created robust discussions based off of history that we've seen in the documentaries and our values as a profession. Remember that provision 8 of the Nursing Code of Ethics requires us to protect human rights, promote health diplomacy, and reduce health disparities. With this project, we wanted to have hard but necessary conversations, and you all have made this possible. You will receive information later this evening about our 4th movie night on April 22nd, where we will watch The Waiting Room and discover how the emergency department has become a healthcare safety net for so many people. We are also looking for our next steps beyond these movie nights and discussions. So at the end of these sessions, we'll send out a questionnaire asking you for recommendations for how you think we should move forward in addressing inequities within healthcare. We thank you for coming, and we hope that you all have a very great night. Thank you.
Thanks, everyone. Thanks for
you.
being here.
Everyone. Thanks everyone for coming.